Thank you very much. Good afternoon to everybody. I'm going to speak about the complication scenarios in left main interventions. I would say that we have a lot of things could happen during our PCI in left main, starting from dissection, aortic dissection also extended from left main, thrombosis, perforation, vessel rupture, wire balloon fracture entrapment, device entrapment, stent balloon embolization, and so on. And iatrogenic dissection will happen. I think that the main thing that to keep the guide wire outside, don't inject at that time, and of course, if you have already your wire there, I think you should do everything in order to keep it, because that is the true lumen, and then this problem can be fixed. Thrombosis can occur during the procedure. The thrombus is injected from the guiding catheter, or formation in situ because of subintimal thrombotic therapy, disturbed rheology from intracoronary instruments, and accidental thrombus migration from vessel to another. So aspiration of thrombus is the main things to do, as well as to reinforce antithrombotic thrombotic therapy. Now, every step in bifurcation intervention in distal left main can carry some problem, starting from wiring both branches, lesion preparation, debulking, balloon dilatation, stenting, and optimization. And a complication can occur at each step of these. Complication due to the wiring might be proximal at the level of the plaque and distally. Perforation can occur particularly if you have CTO, but CTO on left main, I think it is not that frequent. And distal perforation by guide wire, that means in the distal part of the arteries of both branches. Then balloon during pre-dilatation, balloon rupture, balloon entrapment, and dissection caused this can be because of diffuse disease, tortuous vessel, inappropriate balloon sizing, and high pressure inflation. Just an example here, you can see that after pre-dilatation, during lesion preparation at distal left main, we have a huge dissection involving both circumflex, LAD, and left main. Starting from this, I mean that to keep the wire inside and to treat very quickly what happened there. That means to position your stent as soon as possible in order to occlude the entrance of the dissection. And this was done here. And it is only with the simple stenting crossover from left main to LAD was fixing the problem. Another possibility is that with the guiding wire, guiding catheter during wiring circumflex in this case, which was suboccluded, and we have done several maneuvers, dissecting also by the wire, and maybe also the guiding catheter. And again, if still you have any wire there, we were lucky to wire LAD and stent crossover with the with the LAD, and then to recross and treat the ostium of circumflex. Dissection with retrograde extension to the aorta. This is a very challenging situation. And as you can see in this case, after pre-dilatation, just I think the intubation of the guiding catheter was too deep in left main, and this caused the dissection. And again, what to do here is to retrieve the guiding catheter, leaving the wire inside, and as soon as possible to occlude the entrance port of the dissection, that means to avoid extension, further extension of the dissection along the aorta. And this was done. Actually, we could fix it very quickly, and until you see contrast at the wall of the aorta, means that there is no communication between dissection and the lumen. That means the dissection is limited. And of course, the stent helped in order not to extend more that dissection. This was the final result. You can see everything was in place. Still some dissection beyond the stent, but was not that much. And we actually, after post-dilatation of the stent with bigger balloon, we fixed also that segment of dissection. And CT angio was done. CT angio was done a month later, and you see that there is no consequences on the aorta. Perforation, I think perforation at the left main is very rare event, but can occur. And actually the most important thing is prompt recognition. And I think actually if happen, it can be carrying many hemodynamic instability or something that can be very challenging. There are some description. I have never had a perforation left main, but I looked into literature. If the perforation is at the shaft of the left main, that could be corrected with covered stent. And of course, if it is distally, that means near the origin of circumflex, this can be much more challenging in order to fix the perforation. There are some cases or some creative approaches to fix this perforation distal left main by positioning a balloon behind the covered stent, and after that, you are creating two different ways or lumen. One in the covered stent, which covering the perforation. The second is a balloon created by the balloon to the side branch. The other thing is perforation location is very important, and if it is distally, there is some cases reported by fenestration of the covered stent, leaving the wire in the side branch in order to know where to go to fenestrate the covered stent. But I think it is going to be very, very challenging to succeed every time in doing something like this, because I think it's technically very demanding. And as was said, also distally, you should keep under observation your wire distally, because many times can cause perforation, distal perforation, and this sometimes might be difficult to fix. The complication coming from stenting, from any kind of or any strategy of stenting, it could be crossing beyond the stent and crushing the stent, as well as deforming the stent, as well as creating metallic carina with bulky accumulation of metal in front of the ostium of the side branch, which is difficult then to recross and correct your position. Thrombosis during complex stenting in left main, as you can see, you should look very careful about. And I think that you can fix that with aspiration and, of course, the reinforcing the antithrombotic therapy as well. Then the migration of stent or devices, as well as the rupture of wire inside the coronary. Sometimes, if it is distally, it can be left without any consequences. But if it is not, I mean, you are not feeling comfortable with, you can retrieve it with his necks or with double wire approach. And finally, the balloon fixation in migration of the stent. There are many ways to do that, by snaring or by crossing the stent with a wire, inflating a small balloon distally, and retrieving the whole balloon and stent together. Deformation of the stent. This can be seen very easily by stent boost, and it is caused mainly by guiding catheter, which is intubating, or by retrieving the balloon from the coronary, and the balloon is not can be retrieved with a segment of the stent and with elongation of the stent and deformation of that. So many things can happen during your procedure in distal left main, and I think that the main thing is to keep till the patient is stable, to keep calm, not to go for, not to panic, and just think about what you have to do. Second thing, I think that the prevention is much better than creating the problem. And so use carefully, plan carefully your procedure, use whatever it's good for your patient and benefiting from your work. The second, finally, I think that in any interventional cardiologist should expect to have a complication during the procedure, and I think that every operator should be prepared to face this problem. Thank you very much for your attention.